He wished to speak uninterruptedly, but I am here for more time on the dais. So, uh, this is what I discussed, that we feel that we know everything about communication, so what do we need to know about it? But friends, communication makes the foundation for entire management of our patient, right from beginning, before as soon as the patient walks in our chamber, consulting room, whatever kind of treatment, medical, surgical, that we are going to give, until the patient leaves from our hospital. Communication is the basic foundation which is going to help us in long way. So, what are the various situations? Please bear with me, I am an OBGYN and hardcore fetal medicine consultant now, so examples will be more related to OBGYN. I am sure there are few OBGYN there in the audience as well. So, fetal anomaly detected on ultrasound, yes, it's a bad news. Missed abortion, especially primary gravid patient, it's a shock to patient. Intrauterine fetal death, shock to gynecologist as obstetrician as well as the patient. Intra-op complication, cancer detection, advanced stage, critically ill patients. There are many situations where we have to deal with this and how best we can break the bad news. So this is one reference that we all know, Spikes Protocol by Bela et al. In 2000, that we have to take into account the settings, the perception, the invitation, knowledge, emotions and strategy. And summary, I'll just quickly go through these concepts. Out of these, I think two most important are the knowledge, that is the way we explain actually about the bad news to the patient, and emotions. To deal with the patient's emotion is what is extremely important. So setting, where would you communicate this bad news? You cannot just stand in the corridor or in the reception area and break a bad news. No, you have to do it. You have to prepare for the communication with the patient. It should be preferably in your chamber, in your consulting chair, because that gives you an authority to speak. Perception, know about the perception of patient or relative about the disease. Suppose it is cancer related thing, cancer colon or liver or whatever, what amount of knowledge that patient is having about that particular condition. And remember friends, communication is not about speaking. Communication is two ways. It is about speaking and listening to the patient. So we must listen to the patient's concern and try and understand patient's perspective. And okay. Find out how much detailed information they want to have from you. I know these days so many patients Google so many things and they know, but then we have to sometimes remove those concepts and then tell them properly as to what is what. And giving knowledge. Now here again, this, as I feel, is the most important aspect of breaking bad news. Of course it has to be in a simple, clear language without medical jargons, with frequent pauses, but I think very important, couple of warning short statements have to be given. Suppose a patient has been detected in the stage 4 CA breast. You can't suddenly tell the patient. So we have to kind of give some warning shot, in case of cancer, CA breast. It depends when the cancer is diagnosed. If it is advanced stage, say stage 4 or so, the life expectancy is usually not very good, and slowly we build up and then come to the actual bad news. So let the patient and the relatives be prepared, and preferably always explain in her vernacular language so that it's easier for the patient to understand. And when we are speaking, it's not just about speaking. Patient is looking at us as a whole. So our complete body language, smiles, frowns, everything. I'm myself a sonologist, so when I'm doing a sonography also, if I look at the fetus and I feel there is some abnormality, the slight changes in the expression on my face, patient will immediately ask, Madam, kya hua? What is something wrong? They immediately pick up the things. We are not very aware about it, but so we have to be very careful whenever we are talking to the patients. And in speech, of course, the voice modulation, punctuations, pause, confidence, everything matters when you are breaking the bad news. Again, never forget, when you're communicating with the patient, it's not just your lips that speaking, your eyes are speaking. Eye to eye contact with the patient, the relatives matters a lot, right? The patient feels that you have communicated things better if you do it in this way. And well, to every advantage of technology, there is a disadvantage too. We know this, there are so many frequently the phone rings when we are communicating with the patient. But especially in such serious situation, when you are breaking a bad news, put your phone on silent. Tell staff that please do not disturb me for 10 minutes. I'm speaking to this. Because when you are breaking the bad news and in between the phone comes and then the friend doesn't know what is happening. So, aa raha hai na party mein sham ko, aa raha hu. You know? So these are small things but matters a lot for patient. So it also breaks the flow when you're talking to the patient about a particular condition. Again, this is very important aspect, emotions of patients. We know that when ultimately we break the bad news to the patients, the crying, anger, these are all natural reactions by the patient. And we must allow them to express their own feelings, and we must also acknowledge their feeling, a warm hug or even putting a hand on their shoulder that yes, we understand, I can feel what you are feeling right now, but then now we have to handle it, we have to deal with it, and let's together do it. So these few things, basic things, be empathetic, but still honest, provide comfort and healing to the patient. All these basic aspects of our nature is going to matter a lot when we are breaking a bad news. And then making strategy and summary. So after you have already given this bad news to the patient, then you must make a plan as to now what best we can do for you, how best we can, the medical science is going to help you. You have to summarize the discussion and then check patient's understanding. So this was about the basic concepts or idea as to how to deal with breaking a bad news. Now I am going to just discuss about few clinical scenarios in which we are breaking bad news. Of course, confidentiality is something. Suppose if it is a missed abortion at 6 weeks, 7 weeks, and the couple doesn't want other relatives to know about it, then yes, we have to keep this thing also in mind, not to discuss about it in front of other relatives. Now, let's look at some of the different clinical scenarios. As I said that it will be starting with my OBGYN. So early pregnancy, missed abortion. For any OBGYN, 7 weeks missed abortion or 8 weeks missed abortion is not a big deal. You know, we'll just do a DNA and half a day thing and patient will be discharged and fine. But for a primary gravid patient or for any other patient, they are expecting a baby and then 8 weeks there you come to know that there are no heartbeats. It's a trauma. I have seen patients going into depression also because of missed abortion. So now what is important here is, even if you are scanning on your own and you see that there is no heartbeat, do not disclose it to the patient directly. And do not show any expression. Always better to send the patient out, call the relative in, husband or whoever is there. First, tell them that this is the situation, heartbeats are not there. Do you want me to tell patient, or you want to go home and tell her what ways you feel is she'll be happy to receive, or not happy but will be in a position to receive this kind of news that there are no heartbeats in the baby, and then talk about it. So small things will go a big way when you are dealing with this. Intrauterine fetal death at 7 or 8 months. Now we know that we care for our patients, we do all necessary investigations, we do all necessary checkups, but these things do happen because still there are 30-40% causes of intrauterine fetal death where we are not able to pinpoint a cause even after it has happened. So yes, this does happen once in a while. So again, when this happens, when this happens, what we can do? We have to tell to the patient that yes, this has happened, but we have done our best till now, and we shall still investigate further and try to find out if there is any cause for intrauterine fetal death, and try and see that it doesn't recur, and it may not necessarily recur also. So give some hope also, give some support that yes, we'll try and do, but at present what we need to do is to deal with this pregnancy and how to deliver this baby. As I said, in fetal anomaly, many a times I come across some of the lethal cardiac anomalies, some of the lethal CNS anomalies, where again we have to deal with how to tell the patient. Now, why does this happen? That it is difficult for us to break the news in cases of fetal lethal anomalies, because any patient who comes for an anomaly scan at 4.5, the second trimester anomaly scan, 18 weeks, 20 weeks, they do not expect anything abnormal in their baby. Every patient comes smiling, couple, they want to just see the face and limbs, everything on the ultrasound screen, and they want to see that the baby is absolutely fine. So they come with that precondition that the baby is absolutely fine, and therefore counseling, if you have done little homework before doing scanning, or even the obstetrician before sending the patient for this anomaly scan, it becomes little easier if at all there is some anomaly which is picked up. So just telling them that 2 to 3% chance of anomaly is always there naturally in any pregnancy. We are doing this scan to rule out that, and we'll most probably be ruling out anomalies to the extent 90% at 18 to 20 weeks. And let us have a close look at all the structures of baby and then discuss at the end of scan. So little homework before the scan is going to go a long way if at all there is any kind of anomaly which is picked up. Emergency situations, we all have come across this some or the other time in our practice. Unexpected natural complications, PPH, other complications. Now suppose there is a PPH, there is atonic PPH that is happening on the OT table. What is extremely, yeah, just finishing a couple of slides. So if there is atonic PPH, then what is our habit is we give IV fluids and we give oxytocins and we keep on managing the patient to our level best, call for help, call for blood, everything. But we do not communicate with the relatives who are waiting outside. They do not do a thing which is happening in the OT. So a responsible person, either a doctor who is assistant or a senior staff, must go out from time to time and tell that, see, this has happened, the uterus is not contracting, we are giving medicines, still it is not stopping. We have called for help, we have called for another doctor, we have called for blood, we are giving fluids, we are doing our level best. So they must know that in these 2 hours what has happened inside the OT, and doctors tried his or her level best. That is what has to be informed to the relatives. Most of us fail to do that because we are under a lot of stress. And if there was any complications before starting surgery, like severe PIH or anemia, severe anemia, gently but firmly we must have explained these possible complications before starting in surgery, and a high-risk consent should have been taken. Death of patient I'm not going to talk because this is a separate topic in its own. And again here the communication is the key to prevent mob reaction as well as to tackle the mob. So the points to ponder is communication is the foundation to have a good doctor-patient relationship and also to break up bad news, and based on which you'll be able to manage your patients well, and always be patient with the patient to practice medicine patiently without tension. With this, I feel that though we do not stress much on communication, this should be part of medical curriculum, because this is where we are lagging. When we are out of medical school, we do not know about the basic principles how to communicate with the patient, which will go a long way to prevent medical legal problems. With this, I thank you all for patient hearing. Thank you.